Hey everybody, so you all voted for it in the Discord. So we're going to do another tier list. This one's going to be over EMS medication in regards to a paramedic, myself, whenever it comes to these types of medications. Please understand, I only have limited use on some of these medications, even though I feel like I've been doing it for a while. I've also worked as a chase medic or a private care transport for a bit. I've used to work at a clinic, so I have my own opinions on things like labetalol, for instance, as a blood pressure medication. However, your type of practice may be different from mine. Like you may have different experiences than mine. While I may put this somewhere or like activated charcoal, you may have worked in the field for 20, 30 years and you're like, oh, this is the best medication ever. For me, it's kind of just like a filler in the box at this point. I'm more so contact poison control, but we can get into that. Even if you're not an EMS provider, I think you're going to learn a lot potentially about just these type of open discussions. If you disagree with my rankings, please mention it in the comments below. I try to answer everything to the best of my ability. And if you want to take part in future polls on videos that we're going to make, please consider joining the Discord. The link's going to be below. Anyway, starting off with acetaminophen or Tylenol, the only way that we administer it at my current department that I'm working at is we administer it via a liquid. So you have to be careful. This medication is something that you need to make sure you administer to, again, somebody with like a fever or something. You have to watch out for allergies, but you have to for any medication. Regardless, you should always ask about allergies for somebody. This medication is great for somebody who has fevers. We don't administer it as a pain medication where I work at least. And I think it's a great medication. The only issue is I'm going to put it at it's good, but it's not used too often. More so, I'm just going to leave that at, I'll leave it at it's good. The reason why I'm not putting at I love this medication is because you have to kind of draw up the liquid and you have to use like a, maybe like a 15 cc or a 10 cc syringe, consider like a 20 cc syringe or even a 60 cc syringe, just because of the amount of the medication that you have to administer. So that can be kind of a pain. And also, it's really easy whenever you're trying to draw up this medication with a really big syringe that you may end up spilling a little bit of it or kind of making kind of a mess. It's really sticky, so you have to be careful. This is a medication that we administer orally or via the mouth. I usually just give them the syringe and let them kind of push it themselves and drink it. It's very nice to administer these types of medications, especially like an anti-fever, because while we won't see the effects of it, the hospital staff, first off, they're going to be like, why didn't you give them a medication for their fever? But if you do, then the nurses are going to be like, oh, okay, and you set up an IV too, and you started saline, and you gave them acetaminophen or like Tylenol. Fantastic, great job, medics. You get a pat on the back. So it's a good medication to administer. It's just kind of a pain to draw up and give to somebody. Again, we only give this orally or via the mouth. The next one, activated charcoal. Man, if there was a tier even lower than rarely ever needed, I would definitely put it there. And this is more so like, really, I just don't like the medication. I couldn't think of a good way to manage these tiers as far as like listing the names. But anyway, activated charcoal, it's kind of going towards the past now. They don't even really teach it too much in EMTB curriculums anymore. I should know, I help teach EMTB medications. But this medication is really good in the sense of like if somebody overdoses on, let's say, pills, and you see them within the first 30 minutes, what you can do is you can administer this paste. They'll eat it orally. Of course, they need to be alert and oriented times 4. They need to be able to protect their own airway and be able to swallow things. You can give them this paste, and it coats their esophagus, it coats their stomach, and it also coats the pills, so it stops them from being absorbed anymore. You should also contact poison control whenever you're considering any type of poison management, just to start the process. Even if they might not give us any good tips while we're in the field, they may set up the process to where they're working with the hospital staff, and the hospital staff already knows like, hey, this is what I need to do next. So it's really important to save poison control's number. I'm going to go ahead and look it up on my phone right now just because I have it saved. You should always have poison control saved as one of your numbers. And for me, it's 1-800-222-1222. So again, it's 1-800-222-1222. And I would highly recommend, if you're an EMS professional or not, just to save that number and have it on your contact list. It's really important to set up that process as soon as possible. The next one, adenosine. I've seen it work. I've seen it convert somebody from, like, let's say an SVT over to a sinus tachycardic rhythm or a sinus rhythm. I'm kind of on the fence on administering it sometimes. If a patient's heart rate is at like 152, 154, for instance, I'm not really considering saline. I'm considering about just kind of talking to them Maybe consider administer saline, but I won't use this every single time I see somebody in like SVT, just because a lot of times it makes sense for their heart rate to be elevated. Maybe they had trauma, maybe they had pain, and that's what's causing their heart rate to spike, and they have like some type of mild anxiety or moderate anxiety. A lot of times people just need to be talked to rather than being administered this, but at the same time, if I see a heart rate at, let's say, like 220 or so, or in the 200s, then I'm really starting to think, okay, adenosine is probably the way to go. But we have to remember that we're being called out for emergencies, so you don't always need to administer this all the time. You do like a 6, 12, and 12, your total max medication, depending on your local protocols, of course, is going to be 30 milligrams in total. That doesn't mean you push it at once, but you do 6, 12, and 12. It also can be it's not up here because I find it to be a little tricky where you want to set up like an AC vein or IV access or intravenous access. And you want to make sure that you push it and then set up a flush and then push that in 2 to 3 seconds. We don't have a stopcock that we can use to set up both of them, unfortunately, at least at the fire department that I'm at. So you have to be really careful because this medication will die out in like 5 to 6 seconds. So it might not even reach the heart, but it's mainly made to slow the heart rate if it's too fast. Vagal maneuvers are always a good idea too. And if a patient's unstable, we go from medically trying to treat it to, if they're hemodynamically unstable, we'll go to like synchronized cardioversion, where we'll shock somebody back into a normal rhythm. But you have to be really careful and make sure you sync them. This next one here is adrenaline. I love this medication. It's also known as epinephrine 1 to 1000 or 1 to 1. We use this for somebody who's in anaphylaxis. So somebody who maybe was stung by bees, maybe they ate some peanuts or shellfish when they're allergic or were exposed to it, and they're presenting with urticaria or just like hives. We see that they have shortness of breath. This is an amazing medication. This is normally how we actually carry it as adrenaline, or at least at the department I work at. And I find it's not only a really good medication, but like it's also a really good teaching tool. So let's say if I have like a new EMTB who's been writing it with me for a while, let's say like 3 months, 6 months, or I have a new medic with me and I'm teaching them, for instance, I'll kind of take a step back and I'll say, hey, why don't you go ahead and draw up this medication? Why don't you go ahead and administer to them? And I'll watch them pull it out of the medication box. I'll watch them draw it up. Usually they'll kind of have a little bit of shaky hands because, of course, it's a respiratory emergency. And at any time, if I feel like they're doing a bad job or if they're going too slow and my patient needs this medication on the spot in like the next 5 seconds, I'll take over and just draw it up and administer it. But I feel like it's a really good teaching tool to kind of see like, okay, this is their level of a tolerance for working on emergencies, right? And I want to increase that by giving them like a task like to draw up and administer this medication. And afterwards, usually they have a better tolerance to handling these type of emergencies. This next one, Afrin, it is sorry about that. It is a medication that's used for epistasis or nosebleeds. It means the same thing. We can administer this via intranasally. I haven't ever used this on the call, and I haven't ever heard of anybody using this in our department. We just recently got the protocols for it this year, so it's exciting, but I don't really have any good information on it yet. I just have my local protocols, and all we have to watch out for is the diastolic blood pressure or the bottom number for the blood pressure. But I'm still always on the fence of like, was this really necessary? Do we really need protocols for Afrin, for instance? Can't we just tell them to put pressure against their nose? Now, instead of leaning back, you're told to lean forward because they don't want you to aspirate on your blood. So the AHA's kind of changed that. But so you lean forward, grasp your nostrils, and then hopefully that helps it clot up at that point. That's how I was always taught, and I've never seen an issue with it. But I mean, new medications, I don't even really feel like I'm glad and I'm really appreciative that we have these protocols, but I don't know how necessary it really is. It just depends on a case by case basis, I suppose. Albuterol, though, albuterol is a very cool medication, and I'm sorry these images, some of them aren't that great. At first they were cropped and it didn't really show anything, but normally you see that it's inside one of these type of containers, or it's in one of these little, I don't even know what these containers are called. They're not ampules, they're something else, but it's like a plastic container that holds the medication. They're a lot of fun to use. I feel like it's a great tool, especially if we have a student. I will lean towards them to set up the albuterol treatment. It's usually used for like asthma, wheezing. If somebody has bronchoconstriction, which just means tight bronchioles or the tubes that connect to their lungs, we can loosen up the smooth muscles around it by administering a bronchodilator like so. This is a great medication. You put it in a nebulizer, and it causes students a lot of anxiety. So that's why I made a video going over how to administer albuterol via nebulizer, and we set it up at 6 to 8 liters per minute. So it's a really good medication. I think it's a lot of fun, and I kind of like visualizing the mist. I think that it's just great overall. The next one is amiodarone. So I haven't had protocols for amiodarone for 4.5, 5 years almost. It's a great medication whenever you're learning like PALS and ACLS, or like you're learning about just advanced life support in general. People usually lean towards amiodarone because it's a lot easier to teach. Okay, so the first dose for amiodarone is going to be 300 milligrams, and you do a second dose probably like 5 to 10 minutes later at 150 milligrams. Of course, look at your protocols. It's an antidysrhythmic. I personally don't use this. I go more towards like lidocaine, and we'll either do 1.5 milligram per kilogram up to a total dose of 3 milligrams, because then you do 0.75 milligram per kilogram, then another 0.75 milligram per kilogram. For amiodarone, we just don't really use it at my department. I think it's a shame because I think it's really easy to use, and I think that it can be potentially helpful. But I've also heard things that lidocaine's potentially better than amiodarone as far as like for like patient outcome, and I'm familiar with the dose, so I think it's a great drug. I think if your department has it, that's great. We just use lidocaine where I work at, and I haven't had to use amiodarone ever. For baby aspirin, I think it's a fantastic medication. You have to watch out though. People can be allergic to aspirin. They can also be allergic to salicylates. You want to reach the desired dose of 324 milligrams or 4 baby aspirins. Sometimes patients take adult aspirins, which are like at 324 or 325 milligrams for one pill. A lot of people will say, oh, is it 324 milligrams? I was taught it's 325 milligrams. It's like the same concept or the same thing. Basically, it's just 4 baby aspirins. And usually patients that have long-term cardiac issues or cardiac care, if they're seeing a cardiologist, they're usually on 1 baby aspirin or 81 milligrams. So we want to reach the desired dose, being 3 more baby aspirins, adding up to a total of 4 baby aspirins because of the one they took, making it 324 milligrams. You have to make sure they can protect their own airway. You have to watch out for allergies, of course. And just make sure that they took a baby aspirin. Also take note if they take any blood thinners or anything. This isn't a blood thinner, by the way. This is an anti-platelet inhibitor, or a platelet inhibitor from my understanding. So it just stops, it doesn't help break up the clot, but it stops the clot from basically getting any worse. So we want to administer this very quickly if we determine that it's a cardiac issue or a chest pain call. The next medication here, you can't really visualize it, but it's atropine. It's a really cool medication. I find that it's not, I've seen it being used before. You have to watch out because it only works on a first degree heart block and a second degree type 1 heart block, but it doesn't work on a second degree type 2 heart block or a third degree heart block. So it's really important to be able to differentiate your heart blocks. That's why I made a video of that in the past if anyone's interested. It's a great medication. We carry it in different ways. I believe we have like one where you can draw it up, and then we also have one where you can push it this way. So we carry both, which is a little odd. What's really cool about this one, if you ever learn it like medic school, and we do have protocols for it, if somebody gets exposed to organophosphate poisoning, it's really cool. You basically consider like the SLEGEM acronym, where they basically are salivating, they're lacrimating, they have urination, defecation, emesis. I forgot what G is. I think it's like GI issues. I think I already said emesis, right? And meiosis. Basically, the body's like trying to remove the toxins in any way possible. We can give as much atropine as we basically have. So you consider, I think it's like 2 to 3 or 2 to 5 milligrams via IV. So you basically use that until secretions dry up. It's a really cool medication, and a really fun scenario for like testing paramedic students is not really testing it for slow heart rate, but more so to test like, hey, do they know about the organophosphate thing? If not, let's teach them about it. So really cool drug. I would actually put it right here. The next medication, I kind of have to zoom in, right? This is ipratropium bromide, also known as Atrovent. And for this medication, I'm going to put it like right here. I learned whenever I was going through paramedic school from like one of my instructors that some of the inhalers have like a component of like a peanut mixture. So you can actually end up hurting people more if you give this medication. And so if this helps cause bronchodilation, if they're both indicated for basically the same thing, why wouldn't I always just use this? Why would I use this? Well, some protocols do indicate for you to use a mix of both. There's also like duo neb, I read in one of the previous comments. And there's some like mixtures of it. It just depends on your local protocols. But be wary. If somebody's allergic to peanuts, just with that little bit of info that I had, I'm really hesitant about administering this drug, and I'll just go straight to albuterol only. But it just depends. The next one, this is for hydrofluoric acid burns. It's Calgonate. We can use this as a topical cream. I have never had to use this. I learned a lot whenever I went over chemical burns in my medical emergency scenarios. A lot of people were really nice talking about the comments. It's at a 2.5% concentration for topically. And it's a really interesting medication. It's just, we usually just keep it in the box, right? We're just never really going to use it. It's more so just something that we need to have to be considered an ALS unit. This next one here, I have to really look. What the heck is this? Okay, so I had to zoom in a bit. This is calcium gluconate. It's 10% concentration. And we're going to consider using this for, let's say, like a cardiac arrest for a dialysis patient. And you have to be really careful. Normally, whenever you have a down patient, you want to generally consider like sodium bicarbonate. If somebody builds up lactic acid, if because they have all that CO2 buildup in all these different tissues, because they're not properly perfusing because it's a cardiac arrest. Let's say we're 10-15 minutes in, then okay, we want to consider sodium bicarbonate. But if they are a dialysis patient, we actually want to quickly administer calcium gluconate. And we have to be really careful, because if we administer calcium gluconate via an IV, if we administer this right afterwards, then the two medications are going to mix. They may be slightly inside of the IV port, and it'll actually create like a seashell-like composition, and you'll potentially ruin the IV site, and you could really hurt your patient. So be really careful with that. I'm going to put it that this medication's okay. It's really cool if you're working a cardiac arrest and you or another medic, for instance, is like, hey guys, this is a dialysis patient. Don't forget we need to administer calcium gluconate, because it's only you and your partner, and you're doing so many different things. So it can be kind of hard to remember these kind of niche medications. But with proper training, you can reliably pull out this info and be like, hey, we need to administer this drug. And the ER staff will love you if you did administer it, and they will not like you if you forgot to administer this. So be very careful. It's like checking a blood sugar almost whenever it comes to a dialysis patient. You really want to make sure that you administer this if somebody has a cardiac arrest and they are a dialysis patient. This next one is Cardizem. I've only seen it used once where I personally used it. I don't have the protocols for this anymore, so this is a medication that I do not have protocols for, and so I have limited information on it. Some people had issues whenever I went over my medical emergency tier list, and I talked about AFib RVR and how I administered this medication at the time. I don't have protocols on this anymore, so I don't have like a protocol to rely on whenever it comes to the dose on this medication. And I don't know the dose on every single one of these medications. Like I don't know the dose for like ceftriaxone, which is like an antibiotic like Rocephin. I don't know the dose for whole blood, or like all of the considerations, or lactated ringers. It's just, I don't carry all of these medications, guys. So I'm not that knowledgeable when it comes to it, but I have used it once before and it worked amazing. I would love to have protocols on this medication for Cardizem. It's a fantastic medication. It worked wonders. It took care of my patient immediately that had AFib RVR, or like an accelerated AFib rhythm that was starting to become a little bit unstable, right? We gave him this medication, worked fantastic. We don't want to synchronize cardiovert a patient who's on AFib, especially if they don't have blood thinners. If they do, then you can consider it, but contact medical control first. But we don't want to cardiovert them, because the clots that could be forming in the right atrium or the left atrium, they could become dislodged after you synchronize cardiovert them and all shoot out towards the heart and cause like a pulmonary embolism. So you could kill your patient. But giving them something to calm it down like Cardizem works fantastic. It's an amazing medication. Rocephin or ceftriaxone, I can understand why this is on the medic unit for some units. I've had access to it couple years ago on a different private ambulance service. It was the same time where I had access to Cardizem. I don't have access to it anymore. But why is this on the box? Why is this in EMS? Okay, I agree that some of these things, like maybe like this, for instance, I agree that certain things should be on the medic unit, but antibiotics, Why do we have access to that? We don't even really know what the actual infection is. We can make some assumptions, but why am I giving blind antibiotics? This makes no sense. I'm all for giving people more access to medications, and I'm sure there's a very justifiable reason why EMS should have this. In my opinion, unless we can identify correctly what the bacteria is, unless we can do like a some type of blood test where I can tell like, hey, they're more so they're resistant to this and this antibiotic would work great. I don't see why we would ever really want to consider giving a blind antibiotic. And I agree that in some trauma cases or some like severe cases, yes, early administration of antibiotics would be great, but why not just save it for the ER? Work on IV access, work on getting a 12 lead, work on setting up saline if you need to, taking care of your patient. Don't, I think this is completely unnecessary. But I can see why some agencies carry it. That's just my opinion. I'm sure some people in here that may be watching this video have administered this medication plenty of times, and I'm sure they say it works wonder, and that's fantastic. It's just my personal opinion. I don't think it's necessary for us to carry. And now for, I believe this is saline. This is dextrose. That's why you need to read medication bags, right? It's a really small font, guys. I'm sorry about that. For dextrose, this medication works amazing. This is a fantastic medication. The only issue is you have to set up an IV, and sometimes your patients can be combative. Sometimes it can be kind of hard. You also need to be extremely careful because we have to think about what dextrose is. And all it really is just like sugar water, right? So we mix saline mixed with a type of sugary substance. And the big issue is if you don't set up an IV properly and you try to administer dextrose, it can cause the flesh to become necrotic, where you could kill off tissue. You could really hurt your patient. We have it at a 10% concentration. We moved away from a 50% concentration. Not so much because it's less damaging to the patient, which it is because it's a lesser concentration, but because there is just like a lack of access to 50% dextrose. I don't really know why, but I kind of like the idea of a 10% dextrose. It still works great. I'm only going to put it here just because of the dangers of causing necrosis in your patient's tissues, but it's still a fantastic medication. This is diazepam or Valium. It's a great medication. You can only administer it IV, at least where I work at, because it is water soluble. So it doesn't work well if you try to do an intramuscular injection or I guess like an intranasal one. So we're limited to just administering it via IV. I've used it before. I really consider this more so for like pediatrics if they're having a seizure or something like that. But it worked well. It worked really well. I just think that the lack of routes compared to something like Versed, which hint hint is gonna go up here, kind of puts it down here as far as for medications. So I'll do this. We'll do a little screenshot. The next one is Benadryl. It is a great medication whenever you're going down your line of like shortness of breath issues like that. If you're considering like allergies, then maybe you can consider doing Benadryl, just going off your local protocols. It's a great medication for adults. For my protocols, we consider 25 or 50 milligrams. I really like for our pediatric dose. Now, this is just my local protocols. I cannot stress it enough. Please check your local protocols and only go off that. Do not go off the dose I'm saying. For me, it was at 0.75 milligrams per kilograms for a pediatric patient. And I like that. I like how it is a fairly complicated dose because I take a lot of pride in just like knowing it off the top of my head. And anytime I administer a pediatric dose, this isn't something that I would consider is in the same scope as adrenaline. What do I mean by that? If somebody doesn't get adrenaline in a couple minutes, they're gonna die. If I'm going towards Benadryl, okay, I have like some time to work with. If I'm giving a pediatric dose, I'm pulling out my protocols and I'm looking at the dose. Same for like 95% plus of these drugs. Just because once you administer a medication, you can't take it back. And that's for any of these medications, right? And each one has its own consequence for administering it. So you want to make sure you administer the right dose. If you administer, I've heard stories where individuals administered the wrong dose because they thought it was 1 milligram per kilograms for Benadryl. And instead of the ER being like, oh, okay, I understand, you made a mistake. No, they chewed them out. And it's crazy because pediatric hospitals, at least the one that I went to for my clinicals as a paramedic, They were super friendly. The nurses were friendly, the ER staff, just all of them in general. They're sweethearts. You know, they work with sick kids and they are great people. But if you mess up whenever you're treating a kid, their fangs come out and they come out to get you. So you got to know your stuff. So I feel like I'm fairly competent in it. It's a good drug, but you need to know your stuff whenever it comes to administering this. Dopamine, now, even for an agency like the one I work at, where we're like 20, 30 minutes away from the hospital, this and norepinephrine, you kind of want to be like, oh, this is a good medication to administer it, but when am I going to administer it, right? So generally, we want to administer like 2,000 liters of, or 2,000 liters, 2,000 milliliters or 2 liters of saline before I even consider administering dopamine, because usually we want to make sure, hey, can I resolve this hypotension with saline or something, right? And if I want to consider something like dopamine or norepinephrine, well, then I have to be like, okay, well, did I administer that much saline? That's hard to administer that much. And also, you're considering, like, am I washing them out? Am I doing them more of a disservice than a service? And then by that time, where I'm considering moving to this, the only exceptions is like, okay, I've administered like 500 cc's of fluid, but now I'm hearing some like crackling of the lungs or some fluid in their lungs. Now I can start to move over to these medications. It's really niche. Um, but it's a really cool one, right? So if we look at this, if I can just look in a little bit further, it is 800 milligrams in 500 milliliters, or 1600 micrograms per milliliter. And so it kind of uses the clock method. And the way I was taught in school, like we would consider like 5 to 10 micrograms, I believe. I think it was like micrograms per kilograms per minute, and you would vary off your medication dosaging based off of your patient's presentation and like how they respond at 5, maybe move to 10. And the way I was taught was that dividing it by 28 is the magic number. So if I had somebody and I wanted to start off at like 5 micrograms per minute, and let's say they weigh 220 pounds, you do 220 divided by 2.2. That's going to be 100 kilograms. And then you multiply it by 5. It's going to be 500. You divide it by 28. And that'll give me about 17, 18 drops per minute. And that's generally a really good way to calculate these types of medications. And then you set it like a 60 drop set. So I was always taught 28 was the magic number. It's okay, but it's fair. I mean, I've never used it, but I do like just knowing how to use it and knowing like the cases for using it. I like talking about this medication, the same with norepinephrine, and I would actually put it a little bit higher than this. But remembering that magic 28 number really carried me out. And, you know, a lot of times we won't ever use this, but nurses may consider using this or norepinephrine just because they're going to have them for an extended period of time. Epinephrine for cardiac arrest medications is a really fun medication to use. It's really easy to use. You push the whole thing, unless, of course, you have a pediatric patient. But this is just for like adults, pretty much. And it's just really easy to use. You just pop it out of the box, you hook it up, administer it, and then you're done. And what's really fun is this, you can't really see it, but they have this gray little cap that's a protective cover over the medication. And if you push your thumb on the side of it, it just pops off. It feels really great. You twist it on, you push it. It's really easy to use. This one is etomidate. Now, I do not have rapid sequence intubation protocols, but I can recognize it for what it is. A lot of people use this to start off. I think they go between like 0.2 to 0.6 milligram per kilograms. And so if they have like a, let's say if they have a 100 kilogram patient and they do, let's say 0.3 milligrams times 100, so they're considering administering at 30 milligrams. I don't have rapid sequence intubation protocols, guys. And so I'm not really familiar with it. I recognize it. I know some people really like using etomidate to start off their RSI protocols, and you want to sedate them before you paralyze them, because how horrifying would it be to paralyze somebody with a paralytic and then forget to intubate or sedate them? So you have to be extremely, extremely careful with this. I'm going to go ahead and put roconium and succinylcholine. I think it's right over here. I'm going to go ahead and put these all in just the I'm not familiar with them tab. I think it's great if your department carries this. I think it's great if you can consider RSI protocols. I think I've only had one case where I was like, man, I wish I could do RSI protocols, but for 99% of the time, if I'm considering like a significant airway issue where I'm not able to consider, or where I can't drop a tube, I can contact medical control and let them know, hey, I have some morphine, I have ketamine, I have fentanyl, what do you want me to do about this? But I don't have the proper equipment to RSI somebody. I would just drive to. Well, I have a near ER where even though I wouldn't drive all my critical calls to it, depending on the case, I can at least drive over there and they can set up an RSI situation for my patient, and then they can transfer a patient over after setting up like an RSI. So these are great tools for paramedics to have. It'd be nice if I had the access to them. I just don't. So I don't really know off the top of my head the protocols of them very well, just because I don't ever use them, right? So, and so how can I study something that I don't have access to? I can, but it's not very accurate. For fentanyl, I am a big fan of fentanyl. I like administering fentanyl for pain medications. So you can administer this IM, IV, intranasally. You can administer just about every route that you would consider generally for these type of patients. It's great if you're going to move somebody and they're in any pain. Of course, you want to check like a 12 lead. You want to check to make sure like what's their blood pressure at. But you can administer this drug and it works fairly well. It won't completely take away the pain, but it's a good way to start at least your medical emergency for pain management. The next one here is furosemide, also known as Lasix. I rarely ever use this medication. We'll put it right here. I think it's a good medication to have. I think if you're really on top of your game, it's a good process for, let's say, somebody who has fluid buildup for any reason. But it's really rare for me to administer this. I'm sure some agency, they probably, or some paramedics use this constantly on a lot of different calls. I just don't use it that much. And maybe that's kind of a fault on my own, but it's something that I don't really touch up on it. People that I work with don't really touch up on it too much. It's good medication to have. We treat it more so as like a diuretic or let's say like pulmonary edema, things like that. I just personally don't really ever find many cases to use it. But I think that depending on your department, you guys may use this once every 10 calls or once every 20 calls. And I think that's completely fine. I think that it's great. It's just something that I haven't really seen other paramedics use, at least in the field. But I do enjoy having the access to use it just in case I ever consider it. This next one is glucagon. And I had to zoom in real quick. For glucagon, I mean, it's okay. The good thing about it is if you can establish an IV on a patient and you want to administer, let's say, dextrose, and you can't administer them oral glucose because they can't swallow, they have an altered mental status, then we can consider not oral glucose, we can consider glucagon. You can see here that there is two vials here. One is going to be generally a powder. One is going to be just some saline or some sterile water. You're going to draw it up, mix it in with the powder, and then afterwards it'll reconstitute and create like this little solution that you can draw up and administer intramuscularly. For a low blood sugar patients, glucagon basically acts on the patient's glycogen reserves, and it kind of makes them dump all of them to give them a type of sugar boost. It works okay on patients. I've never seen it work too well. I've administered it twice to a patient before and had minimal results and just ended up going to the hospital anyway. I'm not a big fan of using this. I'd rather establish an IV, but I do like how, at the very least, if I have a hypoglycemic patient, I can fall back and be like, well, I can't establish an IV. Well, at least I can do something for them while I'm heading to the hospital, right? So it's kind of a comfort to know in the back of my head, like, oh, I can administer glucagon in case of hypoglycemia or low blood sugar where I can't establish an IV, right? So I do like the comfort of having this medication. The actual effects of it, I don't really see it that much. This next one here, this is ketamine, and I've seen ketamine used before. We use it at 0.3 milligram per kilograms where I work at. Sometimes for, let's say, like RSI protocols or things like that, they'll consider using it at 1 milligram per kilogram. We don't use it at that dose, and you have to be really careful not to mess that up because that's a huge mess up if you're not paying attention to your protocols. That's why before I administer any pain medication, just to be on the safe side, I go ahead and check out protocols on it. I think it's a great medication. You want to be really careful, especially if they have like an eye injury, because this medication causes you to hallucinate and your pupils may be moving around everywhere. And if they have some type of eye injury, even if you cover one, like let's say if they injure the left side, their left eye and their right eye is going to be spazzing out, moving around everywhere, and it could potentially disrupt whatever could be rubbing up against their eye or their sclera. So you don't really want to do that, or just like their lens in general. But for the most part, this is great because this is a pain medication that doesn't cause hypotension, right? So we don't have to worry about a drop in their blood pressure. We still check out vital signs. and I'd still be pretty resistant on administering this if somebody had like a blood pressure on like 60 on 40 or 80 on something. But we don't have to worry about the side effect of possibly causing hypotension. But just be ready because your patient's going to be hallucinating, and just be ready to support your patient. Labetalol. Now, labetalol, where I work at, you need to make sure that somebody's blood pressure isn't 220 over like 110, somewhere around those ranges. It's almost like taboo to administer this medication. I don't know why. Because at the clinic I worked at, we would administer antihypertensive medications all the time. Not so much their blood pressure wouldn't have to be 220 over 110, but we definitely had less restrictions on it. But I understand you generally want a physician's guidance if you're going to be administering this. You don't want to administer this for somebody who doesn't necessarily need it right away. But this medication, I've rarely ever administered. And if you administer it, you don't want to like make up like a modified dose where you do like 5 milligrams because you're like, I just want to give them a little bit. No, you need to give them the required amount. So you consider like 10 to 20 milligrams, just again on your local protocols, depending on if their blood pressure is too high or reaches like a hypertensive crisis emergency. But this medication, it's very rare for me to administer it. I'd put it past furosemide. Probably put it right here. But it's you have to be very careful when administering this medication and watch out because you don't want the blood pressure to drop too low too quickly. So be very mindful of that. Lactated ringers are a great solution to carry. It's fantastic. It's a lot more useful than saline because for saline, apparently what I'm reading now is that this can cause like some type of acidosis buildup, but lactated ringers doesn't really cause that. The issue is that they're expensive compared to saline. So in a perfect world, we'd have just lactated ringers versus a saline concentrate, but that isn't the case. So we don't really carry these, unfortunately. I have worked at an agency that's carried it, but I've never had a real chance to administer it. I think it's great that we carry it. And if you do more research on lactated ringers, it's a really cool concept overall compared to saline. But again, like it's just more expensive to carry. So that's why we not all agencies have it, such as the one I'm working at. And I'm okay with that. I think that this medication's good, but unfortunately the price and the lack of access to it, it kind of pushes me towards maybe like this medication's okay, just because of the lack of access to it, not the medication itself. But that's just my opinion. This next medication here is lidocaine, and it's a really cool medication. We can administer a small dose via IO route or intraosseous where we drill into a patient's bone if we can't establish an IV access on a patient. And that can help numb the area. We'll leave it in for a minute before we administer saline. That way we can kind of numb up the area. We also want to consider it as our antidysrhythmic instead of amiodarone from where I work at. And we can administer this at 1.5 milligram per kilograms. And then we do repeat doses. So we do 0.75 milligram per kilogram and 0.75 milligram per kilogram. Then we move over to a lidocaine drip set where we can administer, let's say, 1 to 4 milligrams per minute, just depending on your patient's case. It's a really cool medication. I think that it's great that we have it. I feel fantastic like going over this medication, and I have a whole PowerPoint or a whole video just purely going over lidocaine and everything that we can use it for at Annabelle Fire Department. But it's just going to depend on your local protocols again. This can be kind of intimidating versus amiodarone just because the dosing is harder to calculate than 300 milligrams to 150 milligrams to a total dose of 450 milligrams. Instead, you have to be like, it's 1.5 milligram per kilogram, then 0.75 milligram per kilogram, then 0.75 milligram per kilogram. But it's supposed to have a possible greater effect on the patient than amiodarone. I don't know how true that is. That's just what I've heard from word of mouth. But it's a cool medication. It doesn't get used all the time by providers simply from the case of like, okay, well, they're in like, let's say VFib or VTAC without a pulse, and we shock them and we're considering setting up lidocaine, but oh, their rhythm changed, so now we're not going to give this. You also need to be careful. If you give this to somebody who has, let's say, bradycardia for whatever reason, you can cause them to go into a systole, so be very careful of that. Of course, you wouldn't even really consider this for the most part for that. But very cool medication. I think it's good. It's just not used that often. So, but it falls pretty well in line in here. I'll put it above these. I'll put it right here. And then I'll put dextrose right here. I think that's fair. The next medication, mag sulfate. I love, so I've never used this drug on a patient before. You consider this as a seizure medication for a pregnant individual. You also consider this for torsades de pointes or polymorphic or multiple forms of VTAC with a pulse. But for mag sulfates, this is a really cool drug to go over and teach individuals on. As far as actually administering it, I've never had to administer it before. I would put it actually right here. Even though I've never used it on a patient, and technically, I mean, it should be down here, right? It's really cool talking about this medication, and this is kind of just me being opinionated too. I love this medication, right? So for mag sulfate, it's interesting because it's at a 50% concentration, but we need to set it up at a 10% concentration. And so you need to think to yourself, okay, if it comes at 5 grams in 10 mLs, how do I get it to a 10% concentration? Well, what we can do is we can pull out a 60 cc syringe, and then we can drop 40 cc's or 40 milliliters of saline from a bag, and then we go up to this medication. We do the saline first because we don't want to accidentally mix the mag sulfate in afterwards. Then we drop 10 cc's or 10 milliliters or all of this medication. And now we made a 5 gram in 50 mLs in a 60 ml syringe. Then we kind of mix it around a little bit. We try to diffuse the medication. And then every 10 milliliters will be 1 gram of this medication. So, right, like preeclampsia, you think of 2 grams. So you do 20 milliliters. If it's 4 grams, or eclampsia, we do 40 milliliters. We never administer the whole thing. And if you're the paramedic, you need to write what the 60 cc syringe has, as well as you need to make sure that no one else grabs it, because no one else should mess with it, because you don't want them to accidentally give too much, because that would be a very complicated situation. But it's a very cool medication. I love talking about it, so I'm just going to put it up here. It belongs here, by the way. It belongs like right over here, even like below like these two medications, so probably like right beneath here. But again, I have to be opinionated. It is a tier list, so I'm putting it up here because I love talking and teaching about it. This is a cool one too, but I've got to put this one here, right? It is Paparin Meat Tenderizer. And I know what you're thinking, why is a meat tenderizer on this tier list? Well, it's on here because if you got stung by a Portuguese man-o-war jellyfish, I've talked about this before, you can get some of this meat tenderizer, mix it up with saline or like just a really like cold water, and you can create kind of a paste and apply it to where the nematode or nemocytes are at, basically where you got stung by a jellyfish at, and that's supposed to stop the stinging effect. So if you apply saline directly to it, you can potentially cause those nemocytes or whatever is causing the stinging sensation on a patient to kind of like reactivate a little bit. So this is a very cool thing that we keep on our drug box. I've never had to use it, but I've always wanted to. And I just love that we have like some protocols for it. It's such a weird random thing to have, but since I live close to a beach area, I mean, it makes sense. Solumedrol, it's okay. What's really interesting about it is you open up this area, you push against here, and it pushes this liquid and this cap to go in to this area where it mixes with a powder and a liquid to reconstitute the medication, kind of like glucagon. We kind of go down our list of treatments, and this is kind of near the tail end for like shortness of breath, things like that. And it acts as a steroid for a patient. We're not going to see the effects of Solumedrol, but it's a lot of fun to set up. But it still is a good medication to consider administering. It's going to depend on a case by case basis, and if you have the time to administer this, because by the time we're administering this, we've already considered like administering Benadryl. We've done Albuterol first. Did we administer adrenaline, Albuterol, Benadryl? Now we're going to Solumedrol. Like, do we even have time to do that before we get to the hospital? But if we do, it's a great medication to consider administering. Versed or Midazolam, I love it. I love it. It's going right here. It's very close to the top, just being next to epinephrine. And it's a very cool medication. We can administer basically every route. I love administering it intramuscularly for seizing patients. I think it's a great go-to medication. But if I can help it, technically diazepam is a better one. Where's that at? I think it's right here. But it's a fantastic medication. Works really well. I have just no complaints. I just have love for this medication. I think it's a great one to have on your box, and it's a lot of fun. It's really easy to use. Morphine, at first, I was kind of a morphine hater. I didn't really move to morphine that much. I didn't like the idea of administering morphine. I stayed away from it. I just used fentanyl and ketamine for the most part. Now, I am a morphine lover. I think that it's a great medication to carry on your box. I think it's a great medication to administer. What I like to do is I'll mix 4 milligrams of morphine and 4 milligrams of Zofran, and I'll administer the Zofran, then I'll administer the morphine. Then the Zofran just helps with the potential vomiting or the rushing sensation that they feel from the morphine, and it works great. You have to be really careful for like a drop in your blood pressure or hypotension, but it's a great medication to administer. I understand it's kind of like taboo because it's morphine, right? But for our patients, we're patient advocates and we want our patients' pain to be diminished. We don't really want to cut it out completely, just depending on the case, because we still want them to get properly assessed by a physician at the hospital. But like for instance, like let's say if you have kidney stones or something, then I'm highly considering giving you a type of pain medication, and I will do the best of my ability to make sure that you have a comfortable transport with us. That doesn't mean that I give this to every single patient, of course, but I consider it a lot more now. And I really like this medication. I think it's great that we carry it. And I love the mix of that and Zofran, doing like a 4 and 4, or 4 milligrams of this, 4 milligrams of Zofran, then we're good. Nitro or naloxone, I mean, it works. It works. It's great. EMTBs can administer via intranasally. And if you can see right here, this is what you kind of stick up their nose or against their nose as you're pushing the medication. It creates a mist. This is known as a MAD device or a mucosal atomizer device. You hook it up, you push this medication in, it creates that spray, and it works for opioid overdoses. So whenever we think of opioid overdoses, we need to look at patients' pupils, right? And their pupils should be constricted. They should be tight. They should be like peppercorns. They should be like little small flakes. Should barely be able to visualize their pupils, and that's the black part of their eye, right? If they are dilated, then we consider them to be on an upper, and Narcan will not work on this. Before I used to work in EMS. Apparently, this used to be something they would give to every unconscious patient. Now we're kind of moving away towards that. I haven't seen that practice being done, but I've heard about it. And we don't just do like an unconscious cocktail where we administer this and 2 other medications to somebody. No, we try to be careful now, and we only administer it if necessary. But it's a great thing to have if you have a loved one who is potentially addicted to opioids for whatever reason. Then we can go ahead, or then at some programs, they actually let you purchase this. I don't know if it's like over the counter, or it just depends on where you live at. And you can potentially save someone's life with this. But be careful, because you're ruining their high. And whenever you do that, they may puke, but they also may get very violent. So be very careful with this. I know a lot of cops are carrying this type of medication. I think it's fantastic. But also know that Narcan is not just used for drug users, right? A lot of times we only think of this as like the stereotype of like, oh, it's for druggies, right? Or, oh, like somebody who probably takes like X amount of drugs, they'll definitely need Narcan. Well, think about this. Let's say you're a 60-year-old male patient and you hurt your lower back and you try to fight it off, but now you're at the point where it's like, okay, I need pain management. So you get prescribed, let's say, tramadol or hydrocodone or something. There's like the 5s, the 7.5s, or the 10s. It's just stronger variations of itself. And you take one of those pills and it's like 7 in the morning, and then it's 7:15. You're like, did I take my pain medication? My back hurts. I'm going to take it anyway. And just taking those 2 pills can put you in an opioid overdose. And you're not a druggie or anything. It's just that you accidentally took 2 medications, and we all make mistakes. And then you get behind the wheel, and then you drive over to, let's say, church or something, and then you end up in a ditch and you wake up, and technically you drove while under the influence, but it's not so much that they were trying to take a drug, it's just they accidentally took 2 of their pills. So be very wary of that. Check your patient's pupils, even if they're not a druggie, because maybe they got into a car accident because they accidentally took 2 hydrocodones, right? So just be kind of mindful of that. It's not just for druggies, right? It's also used, like a lot of people can fall into the indications to where we want to consider administering Narcan or naloxone. It's the same thing. The next one, nitro. You need to be very careful for nitro. Whenever I was taking my EMTB, this was an EMT basic medication. A lot of agencies are moving over to this being a paramedic only drug. And I don't know if the nationals already changed for its standards for this being a paramedic drug. But I know you get taught this as an EMTB still. And this is a dangerous medication. So it's really interesting. This is the only medication that I know about that goes sublingually, at least emergency wise, where you spray it under the tongue. You do 1 spray every 3 to 5 minutes, depending on your local protocols. And It's a really interesting drug because it causes vasodilation. It can open up the arteries around the heart to allow blood flow to go to those areas if we're considering that a patient's having a heart attack, and it can help reperfuse the heart. That's great, but you also need to watch out to make sure that they aren't hypotensive, and if they took any erectile dysfunction medications in the last 24 hours, those are huge contraindications for this medication. You can end up causing a chest pain call to go from like, oh, okay, let's just bring him to the hospital, to, hey, their blood pressure's low. They took, let's say, an erectile dysfunction medication like Viagra, like Cialis, Sildenafil, and now because you sprayed this medication under the tongue, now you've made a pretty bad call to now they're in cardiac arrest because their heart didn't fill up enough with blood because there's just too much vasodilation going on. So be really careful with this. Make sure both you and your partner are on the same page whenever you administer this. You generally want to set up a 12 lead on a patient where you're looking at their heart. You want to set up an IV, have a bag spiked, ready to go. At my department that I work at, this is a paramedic only drug. Even though you're taught this as an EMTP, you have to be really careful with it. This next one here is Levophed or norepinephrine. It's a very cool drug. The same issue that I have it is with dopamine, where I want to administer this drug. I'll definitely consider it for a hypotensive patient, but I have to administer like 2,000 liters or 2,000 milliliters of fluid to somebody before I even consider this, unless of course they have like fluid in their lungs. It's tricky because I generally will never have a use case where I want to administer this drug. So we want to do 8 to 12 micrograms per minute on a patient. It can be kind of tough to get your calculations down, but what we do is the clock method, where we have it pre-set up to where it fits the clock method area, where we do, if it's 4 micrograms per minute, that's going to be 15 drops. Then it's, if you look at the clock, it's like 15, 30, 45, and 60. You do 15 for 4 micrograms, 30 drops per minute, or like 1 drop every 2 seconds. For 8 micrograms, you can do 12 micrograms per minute if you're doing 45 drops, and then 60 drops, or like 1 drop every second, will be at 16 micrograms per minute. Or, yeah, 16 micrograms per minute. We don't do that. We only do 8 to 12 micrograms per minute, but it's interesting to consider. This one is normal saline. I love this medication. I think it's great. Of course, in a perfect world, I would only administer lactated ringers, but that is not the case. This is the medication I carry, and it's fantastic. A lot of times I think that people underestimate, whenever they're going over their cardiac arrest algorithms, the importance of administering saline, because we think about our H's and T's. One of the big things that we consider is hypovolemia. So while I'm working in cardiac arrest, if I'm not lead medic, I'm usually one of the first people that'll be like, hey, we need to get saline on board. We already have an IO established, or we have an IV established. Let's spike a bag, and let's go ahead and put some pressure on that bag, right? So we'll put like a blood pressure cuff around it, or somebody will be squeezing it. And I've seen really great success with cardiac arrest whenever you set up a normal saline bag on a patient. A lot of times people just need some fluids. Now, it can be a little bit difficult if somebody's going through like heat stroke or heat exhaustion, where their veins are fairly deflated because they have severe dehydration. They need this medication, but it's like, okay, well, I can't administer this because I can't set up a line on you. So then it's like, oh, what do we do? Do we drill someone just because we can't do that? We don't want to give them fluids via the mouth because maybe they'll need surgery. Maybe there's something else going on. So there's a lot of things to consider. The only issue that I've been reading up on recently is that it can increase acidosis in patients. And yes, that means that lactated ringers is better, but how much acidosis, I don't really know. Over how much time? Is it enough to where I would be considering like, hey, like this may actually be doing more harm than good? Probably not. They still need to replace some type of volume, but be careful. You don't want to flush out a patient. What I mean by that is, let's say they lost like 2 liters of blood, and then we give them saline to kind of replenish the fluid in their body. Well, it doesn't carry the molecule of heme, or it can't carry oxygen to the tissues. And if you administer too much saline to somebody, well, then you can cause it to where the heart fills up all the way. It pumps to like the lungs, or like from the right atrium to the right ventricle to the lungs, and it can't perfuse anything because there's no oxygen molecules attached to these. It's not whole blood, right? So yeah, it's an amazing medication still. I love it regardless, and this is like one of the most frequently used, if not the most, in pretty much any EMS field. This next one here, let me look at this. It's Zofran or ondansetron. I kind of struggle with pronouncing the name, but it's a fantastic medication. I love it very much. I'm gonna put it right here. And I think it works really well. It's great for any patients who's nauseous, who have vomited or continue to vomit. It's really easy to administer. I can do an intramuscular injection. I can do a intravenous administration. Overall, it's just easy to use, fun to use. I mean, there's just not much thought into it. It's just great to have hands on, and it's a great emergency medicine to have access to. So I'm a huge fan of it. This next one, oral glucose. Uh, you're not going to believe this, but I'm going to put oral glucose way in the back. I mean, I'm probably going to put it maybe right here. Oral glucose, it's a great idea in concept. It's good to have on hands, and every medic unit should have this medication. But you have to think about its use cases, right? So the only time we can really use this is if somebody calls us and they're like, hey, I think my blood sugar is low. This is like a scenario, right? They'll call you and they'll say, hey, my blood sugar is low, but I don't have my glucometer on you. Can you guys check? You'll check their blood sugar is at like 65 or it's less than 70, right? Let's say it's 58. And I'll say, okay, well, let's assess their vital or their mental status now. Do you know your person, place, time, and event? They do, okay. And then I'll say, okay, I check to see if they can protect their own airway. They can. They've been talking to me, so they have the ability to swallow. Looks good. And they're able to answer all my questions. Fantastic. Oral glucose is something I can administer then. Well, their family member is right there. Hey, I have a cup of orange juice. Can I give that to them? Hey, I can make them a sandwich really quick. I'd rather them eat that or drink that than give them oral glucose. I think that them having something solid that they can consume and something sugary like orange juice or Coke, not Diet Coke or Coke Zero, but actual Coke, is a great route to go instead of oral glucose. So I'm not really administering it that much. I'm not too big of a fan of this, but I like using this to test students. And I'll say like, hey, you have a patient, they're unconscious, but you're an EMT basic student. What are you gonna do, right? Because everything's fine except they have low blood sugar. Let's say it's at 30 or 40, and a lot of times they'll mess up and they'll give them this medication, and I'll pretend to like choke and pass away. But really, what you're supposed to do is request ALS intercept like a paramedic, and we can consider administering something like dextrose, right? Or we can consider administering glucagon, but we can't administer oral glucose because they'll choke on it and die. Oxygen, fantastic use, or just fantastic use case in general. I was kind of hesitant on putting this, but somebody in the Discord, hint, hint, you can join that if you like, mentioned that, hey, we should include oxygen in this tier list, and I agree. Oxygen is great piece of equipment that we can have. Some of like your tools, you consider like a nasal cannula, a nebulizer, a non-rebreather, a back valve mask. You consider CPAP equipment. Some people have humidified oxygen, things such as that. You can do blow-by oxygen. There's a lot of different routes for it, and it is a great, extremely useful tool. I think it's just fantastic to have in general. You couldn't be in it running an ambulance service without having oxygen, right? It doesn't make any sense. What I do like the idea of, if you're going to be working long term in like emergency medical care, consider getting like a nasal cannula at like 4 to 6 liters per minute, or consider setting up a non-rebreather at 10 liters per minute and put it on your face for just a moment and say like, okay, this is actually what it feels like. This next drug here is sodium bicarbonate. It's a very commonly used medication. Sometimes we'll consider it depending on the patient's downtime. So if they're down for, let's say, 10, 15 minutes, then it's like, okay, well, we want to go ahead and administer sodium bicarbonate at this time. We do 1 ampule or 50 milliequivalents of this medication. But again, it just depends on your local protocols. We will administer this medication due to a buildup of acid. This is sodium bicarbonate. So we consider it as kind of like a way to use as like a pH buffer. I really like using this drug. I find that a lot of times, like I'll use it on cardiac arrest calls, things like that, and it just works fine. It flows fine, and no one forgets about it ever on a cardiac arrest call, or we don't really forget about anything. But this is something that is on our priority list. About 10 to 15 minutes, and we'll administer it. If they've been down for like an excess amount of time, maybe we'll consider it a little bit earlier. But it's just a really easy drug to use. I enjoy it a lot. Now, TXA is a very cool drug. You generally want to consider it for any like penetrating traumas if they have like more than one injury site, and we're considering that they maybe have a lot of internal like as well as like external bleeding. But you want to be really careful. You don't want to administer it on an injury where it's only the head is involved because we don't want to end up causing a lot of clots to go towards the brain and then it cause like a potential stroke. So it's a really cool medication. I'm a huge fan of it. I'm a huge fan of using it during trauma calls Just be careful that you don't mess up on any of your contraindications. You know, always follow your local protocols. But I would put this medication, I would put it right about, I would say right here. It's a very cool medication. I love that we have access to it, and I think it's great for emergency medicine. I think that it's great to use on traumas. Just be careful. You want to do, depending on your local agency, of course, like 1 gram in a 100 cc bag. You administer it over 10 minutes long. But it's a very cool drug, and the ER staff generally likes it whenever you administer this if you're bringing in a trauma call, depending on the severity of the trauma, and of course, like if it's indicated to use it on that call. Whole blood, whole blood is very cool. If you have access to whole blood, it is amazing. It depends on your agency, of course. It's really hard to get access to this, and you have to be very well trained to be able to administer whole blood. We don't have access to it. I mean, it is what it is. But I know, like in Austin, Texas, they administer whole blood depending on your local agency. What I'd imagine that they probably need to do is have like a critical care like unit, like maybe like a battalion chief that specializes in EMS, emergency medicine, that can maybe drive around with a cooler with some like whole blood, depending on if like they have certain traumas. I heard recently that a unit that's nearby administered it for a GI bleed, and it had really good effects for the patient. So it's really cool being able to see people being able to utilize whole blood. It depends on a case by case basis. Like, I couldn't really see us arguing it for the department that I'm at, because the cases for utilizing whole blood isn't really there that much, and it's a little bit too infrequent. But it would be really nice if, like, let's say, like, if we had an EMS captain on scene or something, or like a certain individual that could maybe meet up with us and say, hey, I have whole blood for like your cardiac arrest, let's go ahead and administer that instead, just to give my patient a higher likelihood of success. You know, I would love that. But very cool. I would just have to put in, I'm not familiar with it, because I'm not really too comfortable on saying much on it, just besides like just my personal opinion that I think it's great that EMS has this as a one of their toolkits. But overall, I haven't ever really messed with it. It's goofy kind of putting Afrin here, and I'm not familiar with it, but I mean, it's just, I haven't ever seen a use case for it, even before and now currently as we have protocols for it. So this is the tier list. Thank you guys so much for watching. I know that some of the text is kind of hard to look at, and I completely understand that. I'm sure that your opinions will differ a lot from mine. I'm sure that some of these medications like labetalol, you're like, oh, I use that on every other call. Or let's say glucagon, he's like, oh, I've only seen it work really well. That's okay. That's great if that's your personal opinion. Please share it in the comments below. I love to read it. Even if you disagree with me completely, even if you think I'm like a fool for writing all of this or doing all this, let me know. You know, I think by talking about medications in a slightly informal approach just creates dialogue that can be useful for future generations for like medical providers. And I think that sometimes we don't take an informal enough approach where we can say like, oh, I like this drug, but I don't like that drug, just off my own little personal bias. I think that it's a really useful thing to go over. But with that being said, guys, if you did like this video, please like, comment, subscribe. It helps the channel out a lot, and it shows me that you like these kind of videos. If you're interested, please consider joining the Discord. We'd love to have you, and we're going to have future polls on new content that we're going to create. But with that being said, I will see you guys on the next one. See ya.